I'd like to call up my colleague Yves Lantin. I told him earlier that I don't have a speaker bio ready. He's an infectious disease microbiologist, a chercheur boursier senior. He's really a clinician, he's a scientist, and he's an administrator because he both runs the infection control service at the Jewish General Hospital, and now he's a leader because he's the president of the Association of Medical Microbiology and Infectious Diseases in Canada. So he has several very important perspectives on AMR, and I'm really thrilled that he was able to join us today. Merci, Yves.
Thank you for the introduction, and thank you for inviting me. All along the meeting today, I've been wondering how can I frame my talk, and I think I've found a way to tell you a little bit what we're going to be talking about today. Stuart Cole gave you a very, very macroscopic view of AMR. So then we've been to very microscopic vision of AMR, going all the way down to molecules and enzymes. I'm going to give you a mesoscopic view, which is just in between, meso. So mesoscopic, which is a little bit like the vision of Canada in terms of AMR. So now, next slide, sorry. Next slide. So we're going to review a little bit the burden. I know we're late in the presentation and in the meeting today to talk about the burden. We should usually be in the beginning, but I think there are some key points that I'd like to share with you that would be different from what you've seen already in the previous presentations. Review some challenges and what we call, I would say, pain points regarding AMR fight in Canada. And also evaluate some, what does AMI Canada, which is the National Association for Infectious Disease and Medical Microbiology, what do we do to fight AMR? These are my conflicts of interest. I have no relationship with the industry. Definition and burden, just to highlight the fact that, we keep talking about AMR and we keep bringing bacteria up and saying this one is an AMR, this one is not. For those of you who are not familiar with the topic, there's no strict definition of when does a bacteria become an AMR, right, or a multi-resistant organism. And the list is actually a moving target. We're constantly adding new bacteria or microorganisms to that list. And there's always new ones that are, current ones that are being removed. So currently, for example, Candida auris is the new kid on the block from which we're really, really worried about. It's spreading not too much in Canada for now, but it's really, really spreading rapidly in the United States. But we used to be worried, for example, about gentamicin-resistant Enterococcus, which I don't think nowadays is keeping anybody up at night, right? It's not something that we're worried about anymore. Or the extended spectrum beta-lactamase Enterobacteriaceae, which some countries are really worried about, but I would say has fallen off the radar in Canada. In terms of burden of the disease, you've seen the data. Stuart Cole presented the data that presented 1.3 million deaths a year associated with AMR worldwide. But just wanted to give you some perspective regarding what are the other main causes of death. And I think what is striking is to put this number into perspective with the number of deaths associated with HIV and malaria. People who went to school a few years ago remember that these used to be the great killers, killing 1 to 2 million people a year, each of these diseases. But we've made great strides. And nowadays, only about 700,000 people die every year from HIV. And about 600,000 people die every year of malaria nowadays. So AMR is now killing the same amount of people as malaria and HIV combined. This is the new reality now. And what is striking is the discrepancy between the threat and how much money we're investing. Here you see the number of people who are dying for each of these diseases annually. The dark red square here is directly attributable to AMR because you can die from an infection that you would die anyways if the bacteria was, because it's a sensitive one, so it's associated with attributable. But what you see here is how much money we're spending, and you see that the money is not going where the threat is nowadays. We're putting a lot of emphasis on TB and HIV and malaria, but we should put more money into fighting AMR given the number of people who die from these diseases. I'll be focusing a lot on the carbapenem-resistant organism because the forecasts are that this is the greatest threat right now to, in terms of AMR. When we're forecasting, well, the number has increased by 70% over the last 20 years, 30 years. So really, this is a big threat. What's the situation in Canada in terms of carbapenem-resistant organism? Well, there's a CNIS, the Canadian Surveillance Program, the National Surveillance Program, has been tracking the spread of carbapenemase-producing organisms for many years. It's good to review a little bit the data. And the data we're seeing is that there's an increase. Of course, the increase both in terms of colonized individuals, so they're not dead, they're not infected, but they're just colonized, and also an increase also in the number of infected individuals, with an increase in the incidence density here, where you calculate this by dividing by the number of patient days in hospitals. First take-home message, this here is not a linear trend. This is an exponential trend, which means that the spread of these organisms in hospitals is accelerating. The other thing that is striking is that the main driver is nosocomial spread. These pathogens spread in hospitals. And here you see the incidence rate both of colonization and infection, but the orange line here is nosocomial acquisition. Community acquisition would be the turquoise line here, which is almost invisible because it's so close to zero for infections, and it's very low as well for colonization. So you see that the main driver is patient-to-patient transmission in the hospitals. So I think this is, for that kind of pathogen, hospitals is the main focus of the fight. Of course, we're not talking about other pathogens like antibiotic-resistant Shigella. This is a community problem, right? But for the CPE, the problem are in the hospitals. Now, you're going to tell me, yeah, it's increasing, but it's increasing worldwide, right? So is there a reason to worry about this specifically in Canada? So how are we doing in Canada in terms of our positioning, in terms of magnitude of the CPE problem? And this is something that I have to say, we're really weak in Canada into comparing ourselves to other countries. This is a weakness of our surveillance. So we know very well we have a number, but we don't know if it's good or bad. So there's a way to do that. And the way to do that is to compare ourselves to the ECDC. The ECDC have been very pragmatic in the way they trend antimicrobial resistance. They select a few pathogens, and they track the proportion that are resistant. And they select only a subclass of infections, which are called invasive infections. So they take, for example, positive blood cultures. It's undeniable, the patient is infected, it's relevant, it's dangerous. So what's the proportion that's resistant? So here I'm showing you the data from 2024. For those of you who saw me talk yesterday, I updated the slides, so it's even more interesting. So this is the proportion of Klebsiella pneumoniae in different countries in Europe that are resistant to carbapenem. So you have some countries, Scandinavian countries, of course, are the best. Less than 1% of their strain are resistant to carbapenem. You have middle of the pack, Germany, France, 1 to 5%. Then you have those who are struggling a bit more, Spain, 5 to 10%. And then you have really Italy, over 10%, and Greece, over 50%. Croatia being 25%. So how do you think we compare? Canada, are we like Scandinavian country, or more like Italy or Spain? We're not actually very good. If you look only at the central line-associated bloodstream infection in Canada, the proportion of Klebsiella pneumoniae that are resistant to carbapenem is now at 7%. So we'd like to think that we're a Scandinavian country, but from that aspect, we're not very good. And there's another one, which is E. coli. And E. coli resistant to carbapenem, we're at 2%. And we're also right in the middle of the pack. We're not a leader for E. coli as well. So these two indicators are not very good in Canada. I think things are not going well in our country. And of course, we're talking about carbapenem resistance, but these bacteria, because of plasmids, are usually resistant to many other antibiotics. So here you have different species, Citrobacter, Enterobacter, Klebsiella, that are all resistant to carbapenem, but also you see what other antibiotic classes they're resistant to. And you see that most of them are also resistant to quinolone or trimethoprim sulfamethoxazole or even the aminocytes because it's a package deal in plasmids. So how do we stop the spread of these microbes in Canada? Well, I could pull out the Canadian Action Plan, but I thought that it would have been presented by then, so I presented instead the CDC plan from 2019, which has not been pulled off the website yet, which is good. But their data regarding resistance is not available anymore online. So it's infection control we need better tracking of the data. We need better antibiotic use and better antibiotic access. Stuart Cole talked a lot about the pipeline drawing up. I'm going to give a Canadian perspective on this question. We need better vaccines, therapeutics, and sanitation. Mainly, this is for low and middle income countries. So what are the challenges? Or I was invited to talk a little bit about what I think are the pain points. I would say one of the first pain points is that the honeymoon is over for infection control. When COVID hit, we thought that's it. Now, finally, people are going to take infection control seriously. And it's true that at the beginning of the pandemic, there was a 50% increase in the number of publications related to infection control, which made sense, right? And the increase we felt was going to maintain over time. But 2025 arrived, and the honeymoon is over. The number of papers is just back to the trend that it used to be before. So all the gains we made during the pandemic is back to normal. And I'm just showing you here the comparator, which is stroke, and you see that the trend is similar. So my hope that it would trigger a trove of research in infection control has not materialized long term, as if we had a very, very short memory of how important infection control is. There have been topics like hand hygiene, where the number of publication is not only slowing down, but just completely stagnating, whereas it's a very, very important topic. Another weakness of the fight against these AMR is those scientists, I would say those scientists, who actually want evidence-based proof that an intervention works before implementing it. An example of that, the fight against VRE. So people are arguing if there's evidence strong enough that proves that screening and isolating VRE patient works. But these are communicable diseases, right? And they're spreading rapidly. So while you're waiting for that evidence to materialize, the disease is just spreading. And by the time you have the evidence, now it's too late to go back because you've wasted all this time waiting for the evidence to come. So for infection control diseases, for infection control purposes, sometimes it's better to shoot first and ask the questions later because time is really, really super important, and the windows of opportunity are closing very rapidly. I'll give you examples later using CPE as an example. Another thing that people are not completely realizing is how interdependent the different institutions are in terms of infection control, combined with the fact that there's always laggers in terms of controlling their pathogens. If we look here at the incidence of VRE in different hospitals in Canada, you see that there's a big heterogeneity, with the bigger centers, those over 500 beds, having incidence rates that are much higher than the smaller hospitals. But what people don't necessarily realize is the spillover from these hospitals to these smaller ones, because they're central hospital, and they're the mothership. They're the academic centers where patients are constantly transferred and sent back to those smaller hospitals afterwards. Hospitals are not islands. They're not isolated from one another. They're constantly sharing patients and healthcare workers. What is the impact of a single hospital not controlling an AMR, for example, VRE, on the neighboring hospitals? I don't have data specifically for the CPE, but there's been some interesting modeling studies done for VRE that showed that if one single hospital sees a 10% increase in VRE colonization, well, you have to expect an increase by 3% in the neighboring hospitals just because of the spillover effect. And the larger the hospital, of course, the more central that hospital is, the greater the impact on the other neighboring hospitals. So how does this translate to the CPE now, the carbapenem-resistant organism? I think that this is one of the most striking data. These are data from Quebec. There's the similar data in Canada. I just don't have authorization to present you the more recent data that shows there's 88 hospitals in the province, and they all participate in surveillance of CPE. If we look at them in terms of incidence rates, you can have very small hospitals have higher rates, but that's just 2 cases because they're just very small, right? You can have another hospital that has exactly the same rate of incidence, but because it's a much larger hospital, they contribute to a greater number of absolute cases in the province. So when you look at where are the cases in the province, what is striking is that you have most hospitals have 0 cases. Here you see 0 cases over time. There's less and less hospitals that have 0 cases, but most hospitals have no cases, or very few cases, 1 to 5 or 5 to 10 only. You have this small group of hospitals that have more than 30 cases a year. But when you look at their share of the provincial rates, these 12 hospitals represent 50% of all the cases in the province. So a minority of hospitals drive the majority of all the cases. So from a healthcare perspective, the logical thing would be to drop the rates in these 12 hospitals, right? But all the energy in these 12 hospitals, if you could decrease by 30 or 50% the rates in these 12 hospitals, you would have an impact on the provincial rate. It's a little bit, the analogy is a little bit, you know, if you have a village of 100 houses and 12 are on fire, is the solution to install smoke detectors in all the houses, or just go and extinguish the fire in these 12 houses that are on fire, right? This is what we're not doing, because when we reach out to the public health or the ministry and saying you need more resources in these 12 hospitals, we got answers such as, but you're going to reward lack of efficacy. These hospitals have wasted, you know, are not able to control it, and you're going to reward them by more resources, which is completely against the logical way of controlling outbreaks, right? The other thing that is striking is the number of hospitals that have a lot of cases is increasing year after year. So the window of opportunity to impact is closing rapidly. If we wait 4 or 5 years, we may not be able anymore to act on a few hospitals anymore. There's even studies now that show that thinking at infection control from a systems perspective works. There was a very interesting study that was published in JAMA last year that looked at what if we decolonize patients, but throughout the network, not only in acute care hospitals, but also in nursing homes and also in long-term care facility. Because patients in long-term care facility, they constantly come to the hospital and then they go back to their long-term care facility, right? So, and this really interesting study, which is a quasi-experimental study, by the way, but I don't want to go into the detail of the methodology. It showed that if you decolonize patients throughout the network, the entire network benefits from it. Nursing homes saw a decrease in MRSA, VRE, ESBL rates. The long-term care facility, a 33% decrease in MRSA, VRE, ESBL, and the acute care facility also saw a 15% decrease. So it's important to think of the problem more systemic level, not only the microscopic level of a single institution, which we tend to do way too much in Quebec. Another thing I think that is really problematic is how short-term of a memory we have and our incapacity to learn from our past mistakes. And I'll give you just one example. Again, I'm going back to VRE, but you'll see why I go back to VRE when we're so obsessed with CPE. Let's go back to the 2000s. For those who were already practicing then, we used to be damn afraid of the VRE in 2000. Why? Because there was no other drug available. These were infections that were not treatable at all. There was no antibiotic that were effective against VRE. It was even in the news. You see Superbug, BBC News article from the time. But then we stopped worrying about VRE. And why did we stop worrying? Fast-track approval of linezolid. The FDA fast-track approved linezolid, and shortly after, daptomycin came. So now we have 2 drugs to treat VRE infections. We even have tigecycline now, so 3 drugs. And people start arguing about, should we control VRE or not? And nowadays in the United States, most hospitals don't even screen or isolate for VRE. And this is why, when you look at the proportion of Enterococcus faecium that are resistant to vancomycin in the United States now, that are causing central line-associated bloodstream infection, catheter-associated urinary tract infection, pneumonias, surgical site infections, 80% are resistant to vancomycin. So VRE is the norm now in the United States. In Canada, it's 23%. In Quebec, it's 6% because we never stopped fighting against it. What do you think is happening now in the United States because of so much VRE? Well, they're using a lot of linezolid, and they're using a lot of daptomycin. So what are we seeing now? The rise of VRE that's resistant to linezolid and daptomycin. And these are very, very weak drugs. If you look at vancomycin, it took 16 years between the marketing of vancomycin and the appearance of the first vancomycin-resistant Enterococcus. Linezolid, marketed in 2000, first linezolid-resistant strain, 2001. Daptomycin, 2003, first strains, 2005. Single point mutation it will confer resistance to linezolid. So here, the arms race is starting again, right? We used to use vancomycin, VRE came, now we're using linezolid and dapto, they're becoming resistant, right? We're just repeating history. And now, Mayo Clinic, hepatology unit, single patient treated for months with linezolid for an intraabdominal infection, strain became resistant, 5 additional cases on the ward, 1 additional case outside the unit. Congratulations, you published in the New England, linezolid-resistant VRE, first outbreak described. But it really, and it's 2002, it's only 2 years after marketing. So I think the best way to preserve these antibiotics is not to allow VRE to start spreading in our hospitals. Lack of access to the new antibiotics. Stuart Cole presented a lot about the fact that the pipeline of antibiotic has been decreasing over the last few years. And these are data from 1980 to 2012 that really shows that we're not coming up with new antibiotics anymore. But the United States kind of managed to buck the trend. These are data from 2012 to 2019 when 17 new antibiotics came on the market. The problem is that there's no trickling down of these new antibiotics to Canada. And I think this is a problem that we have in our country because, yes, you have to fight AMR, but you also have to provide access and adapt to AMR and be able to treat patients who have multi-resistant organisms. There was a very interesting paper published in 2022 that looked at how many new antibiotics have been approved in various countries around the world. And how do you think Canada did? Worse. So out of the 17 that would approve in the US, about 15 were approved in the UK, 5 or 7 in France and Japan, and Canada, 2 only out of 17 had been approved. Now we have a third one, meropenem vaborbactam, which was just approved this summer, but it's nothing. And we're in a situation now in Canada where we have antibiotics that are deemed essential by WHO, meaning these should be available to this country widely to your population. And these are all the antibiotics that are deemed essential by WHO that are not available in Canada. Bedaquiline, we spoke a lot about bedaquiline. Well, now Merovabor now is approved. But we have a problem now in Canada with lack of access to the newer antimicrobials. This is in part because of the special access program, meaning that since they're not approved, you have to go through all the loops of asking for special access from Health Canada. And it is a barrier to equity because maybe the bigger academic centers have expert pharmacists will go through all the work of applying for these authorization for these drugs, but the smaller hospitals will probably not do it. And right now in Canada, we're seeing patients who have bacteremias due to CPE, so very resistant organisms that are treated with a quinolone. not because it's a first line, right? It's not a first line at all in terms of treatment, but because it's accessible. And the better drugs are just not accessible. I'm going to run out of time to present what is AMI Canada doing to fight against the AMR, but I'm still going to go over it. It's the largest association of infectious disease and medical microbiology in Canada, of course. So we're acting at many different levels to try to fight the AMR, coming up with guidelines. We're also a co-lead in the CNIS surveillance program. A lot of education material. We have the largest infectious disease meeting in Canada every year. We do a lot of research and knowledge translation, collaborating societies. One thing that I would like to bring up, which is directly related to AMR, is the new the Canadian antibiotic treatment guidelines that was just launched last week. So this is a collaboration between AMI Canada, First Line, a company who makes the app, and the Public Health Agency of Canada. And you can now download it if you're a clinician. The QR code is there. But this will give you treatment guidelines regarding many different syndromes, bronchitis, pharyngitis, CAP, sinusitis. Of course, for infectious disease specialists, that may seem to be, it's not the target here, the target audience is not specialists of infections, but more the community doctors, first line. Why? Because 90% of the antibiotics are consumed in the community, right? Not in a hospital setting. So this is really something that we're proud of. We're going to keep on adding new syndromes as we go, as the work goes. But this is something that we're really doing here to try to help people use the best antibiotic for the shortest period of time. So I'm going to stop here just to respect the time, and we'll take questions.
Thanks, Yves, for being on time and allowing some time. Bastien, you have a question?
Very interesting. The 12 hospitals, are they just the bigger centers, so that's why they have 50% of the cases, or are there really bad ones in there? And what are the names?
I don't remember all the names by heart. But yeah, they tend to be bigger, of course. One of the reasons why they have more cases is that they're larger, so of course. But I think here the take-home message is that only a minority are responsible for a majority of cases, right? But yes, CHUM is there, the Jewish, where our work is there, full disclosure. I think the Royal Victoria is. Maisonneuve. There's probably a relationship also with the age of the building. The older hospitals have a harder time controlling the spread of these bugs. So yeah, but sadly the ministry is not doing anything to try to help these centers control it, because that would be for the benefit of the entire population of Quebec, not only the hospitals themselves.
So it looks like Martin's there. Did you lend your pointer?
I did, yes.
Okay, I was afraid it was going to play music. But I thought it was like booby trapped.
I can be arranged. This might be asking for too simplistic an answer, but the Southeastern European countries that are up at 50%, what are they doing so wrong?
I think we have to keep an open mind. It's really tempting to think Scandinavian are very good, and they're really strict on antibiotic use. You know, even penicillin resistant for pneumococcus is super low, right? It seems to be not only for CPE. But one thing that is striking for Europe is this north-south gradient, right? Where the southern you go, the more cases you have. And I wouldn't be surprised if there's not a reason from climate-wise, right? Warmer climates. India has a big problem as well, right? So the southern countries may be a little bit victim of this, but I wouldn't explain the situation in Canada, though, at 7%, where we should be, if it's the case, we should have good rates, right?
Yeah, just as a follow-up, it's a similar question. What role do you think is the data sources? Because even the CNISP data, you're presenting CLABC isolates versus some of the European centers are looking at all bacteremias. So that might dilute, or
Yeah.
we are probably enriching? And could it be the same thing in some of the southern European countries?
Yeah, it's a good point. It's true that when I compare the invasive with invasive, but they're probably not exactly the same data sets, you're right. But I think it illustrates that you shouldn't track the propagation of those germs only through the surveillance program of CPE, right? You have to dig and extract the data from other programs to try to create a good narrative that gives you a better idea of what the situation is. It's something that we should push a little bit more. I think the ECDC has a good way of tracking across countries, and I really encourage Canada to copy that protocol to be able to put Canada and compare it with the European countries, because comparators are really, really strong motivators for improvement. So this is something that we should try to force a bit more. I'm sure the data is there. We just have to aggregate it and extract it. It's not difficult. We're only working on available strains.
Dominique.
Just a small comment on the climate aspect. Sometimes we see this climate as being macro. There's some interactions also with the architecture. I'm from wastewater, in the field of wastewater, and when I did my first sabbatical in the UK, I realized the wastewater in the UK runs about 5 degrees Celsius lower than in Canada. And I realized that they actually have their pipes, their drain pipes, outside of the buildings than inside, which probably explained this difference in temperature. I'm saying that maybe there are these interactions, just reinforcing what you were saying, but maybe there are other interactions with the climate that could reinforce some of these signals that we're seeing.
Yeah, it could do with the water. I mean, in Quebec, I mean, the running water at water, you know, the treatment center goes from 3 Celsius in winter to 18 Celsius in summer, right? So the water temperature changes all the time. We know that warmer water will promote plasmid transfer between bacteria. So that could be the cause. It could also be unrelated to the water. For example, we know that sweaty skin is more contagious than dry skin. So in summer, if patients are warmer and they sweat more, they're probably more contagious. Or maybe survival on inanimate surfaces is easier during the summer months because it's warm. So the exact way through which temperature influences, you know, this phenomenon is not entirely understood. And I think maybe each of these factors play a role.
Yeah, no, it's interesting. Talking about sweating, we certainly heat up our buildings a lot more than in Scandinavia, among other things.
True.
All right. Well, we can discuss that over drinks. We'll probably need some vodka to discuss the Scandinavian heating system. Thanks for that, Yves.
So I just want to say a big thanks for everyone being here today. Special thanks to all our speakers, Professor Heather Monroe-Broom and Dean Follow also. And a special thanks also for our MI4 teams and the planning committee, and also the technical here service and photographer also. Our special thanks to the AMR Center for helping us organizing this activity today, and to Suzanne Havon and the Dogon Foundation for joining us today. So just keep in mind, we have a special seminar also coming this Friday at 12 with Eric Nilsson. If you're interested, I think it will be good to join us there also. And just to let you know, there is the MI4 seed funding grant, round 7, will be launched on Wednesday, November 26th. So be ready for that. And if the Family Foundation is here, so we just want to thank them because for the sponsorship. And watch our annual review is there. So we get a feedback last year and we learned. So we decided to put a cocktail and networking. So welcome to join us and so we can chat, extend the conversation. And thank you again, and I hope we can see you soon in other events. Thanks again.